A very warm welcome to all our discussants, the speakers, and our delegates, and all the viewers. So, welcome to one more episode, in fact, the 42nd episode of the AIOS ARC PG program with a difference. Thanks to the guidance of our AIOS President, Dr. Samar Basak sir, and the ARC Chairman, Dr. Prashant Bavankule, we have had a series of extremely interesting ARC webinars, including the PG programs with a difference. And each time we have tried to include certain special topics which are not routinely discussed for the postgraduates. And we have been very, very fortunate to have with us esteemed discussants and speakers who have enlightened our postgraduates with their knowledge. I'm sure even today, all our postgraduate students are going to be really helped because of the efforts taken by our speakers and our esteemed discussants who are going to discuss the very interesting topic of AI in ophthalmology. So at the outset, I'd like to first welcome our esteemed discussants, Professor B.N.R. Subhadhi sir. He is a retired professor and HOD of the MKCG Medical College, Behrampur, and the chairman of the Ruby Eye Hospital in Behrampur, sir. So welcome you, Dr. Subhadhi sir. We would like to welcome Professor Dr. Kavita Bhatnagar ma'am. She is the professor and head of Department of Ophthalmology, All India Institute of Medical Sciences at Jodhpur. Thank you so much, ma'am, for being here. A very warm welcome to you. We would also like to welcome Professor Dr. Rajesh S. Joshi. He is the professor and head of Department of Ophthalmology at the Government Medical College, Akola. Very warm welcome to you.
Thank you.
So they are going to be our esteemed discussants for the day. And a warm welcome to our esteemed speaker, Dr. Arka Prabha Pradhan. He is the Associate Consultant of Vitreoretina at the Shankar Chennai. A very warm welcome to you. And I'm sure you're going to enlighten all of us with your fantastic talk on a very interesting topic on AI in ophthalmology. So over to you, Dr. Pradhan, sir.
Yeah. Thanks for the kind introduction, and thanks to Academic and Research Committee of AIOS for the opportunity to present today. I hope my slides are visible and I'm audible.
Yes.
Yeah. So good evening. Today I'll be talking on artificial intelligence in ophthalmology, the current status, and what are the future perspectives. This is a very emerging topic, and it can come as a theory questions in DNB and MS examination. So we'll start. So the most complex network and the most powerful system cannot match with the human brain. So matching it is the goal of artificial intelligence. It is everywhere, from the Apple Siri to Facebook, from our car to the house. So these are the few examples where the artificial intelligence is using in our daily life. So this is the taxi booking app, and there's voice assistants like Amazon Alexa or Apple Siri, or there is entertainment streaming app like Netflix, and the image recognition through the Google Lens, and the navigation and travel by the Google Maps. These all are the example of artificial intelligence whichever we use in our daily day-to-day activity. So the official idea and the definition of artificial intelligence was coined by John McCarthy way back in 1956. There are many more milestones. Among them, the important few milestones I will discuss. So the CASNet, which was the glaucoma screening tool, was launched in 1976. And in the year 2000, the deep learning system came. And in the year 2011, the Apple's virtual assistant, that is Siri, is integrated into the iPhones. And the year 2000 was for the Amazon's virtual assistant Alexa, which was released. And in the year 2017, the first FDA approved cloud based deep learning application was used in the healthcare system. And in 2018 to 2020, many AI trials was done in the specialty of gastroenterology. So what is artificial intelligence? It is a computer system that are able to perform tasks normally requiring human intelligence. So there are few important terms in case of artificial intelligence. One is machine learning. It is a subset of artificial intelligence. And another one term is called deep learning. So the deep learning is a subset of machine learning. So among this machine learning and deep learning, so mostly whatever AI system is using in the medicine or in ophthalmology field is the deep learning based system. So what is that? So it is used to extract the progressively higher level of features from the data. And last but not the least is the convolutional neural network. It is the network used in machine learning and deep learning system which connect the input to the output layer. So this deep learning algorithm consists of layers that receive inputs, assign importance, and cluster all these inputs and used for the image recognition, processing, and for the classification. So mainly there are two types of artificial intelligence. Most of the artificial intelligence that surround us today are the weak artificial intelligence. That is Apple's Siri or Amazon Alexa. There are one term called strong artificial intelligence. So what is that? It is actually a theoretical form. There is not much practical example for today. But the science fiction and in the superhuman and up computer assistant in 2001, that's called Space Odyssey, it can be few examples of the strong artificial intelligence. So now I'll come to machine learning and deep learning. So what is machine learning? So in machine learning, we can see there will be one input layer, one output layer, and in between there will be neural network. But here the number of the neural network will be less. It will be one or two only. But the deep learning system, it involves artificial neural network, which consists of multiple layers, 1, 2, 3 layers here, or it can be more than that, multiple layers of artificial neurons to stimulate the physiological function of the human brain. So it can be trained to extract and process the information in the form of images, in the form of text, or for the speech recognition. So artificial intelligence in medicine is one of the fastest growing branch and bringing the revolution to decrease the burden on doctors. So it can detect the lung cancer, can detect the lymph node metastasis secondary to breast cancer, and it is a real-time detection of the colonoscopic polyps and adenoma and can detect the cardiovascular risk factors also. So AI is taking over the world and ophthalmology is not a exception. And it is an ophthalmology is an image-based specialty and has a great scope for the artificial intelligence. So the artificial intelligence in ophthalmology, so what are the uses? So it can be used in diabetic retinopathy, can use in ARMD, age-related macular degeneration, can be used in the ROP screening, may be used in the amblyopia screening and strabismus for to take the decision for the strabismus surgery and for the glaucoma screening and to detect or screen the cataract patient in the time of the cataract surgery and IOL per calculation and in case of keratoconus also. So why diabetic retinopathy? Because approximately 3 million of people aged 40 years or above have the vision threatening diabetic retinopathy in India. So screening is needed with utmost emergency. Hence the role of artificial intelligence in the screening of diabetic retinopathy. So nowadays screening usually has been done with indirect ophthalmoscopy, direct ophthalmoscopy with slit lamp and with slit lamp with 78D or 90D lens system, and can be done with the fundus photography. But these procedures have many challenges. Main challenge is the availability of the human assessors and long-term financial sustainability. So the Smart India study, which made a revolution in diabetic retinopathy screening. I'll show one small video. So in this, it is the comprehensive India-centric evidence of diabetic retinopathy. Multiple center was involved in India, and there are 4% of the people had the visual threatening diabetic retinopathy. And the diabetic retinopathy is no longer is an urban problem. It can be seen hugely in the rural population also. So we have to give some priority areas in diabetic retinopathy screening. So how to identify the priorities or whom to give priority for the diabetic retinopathy screening? So people with known diabetes aged 40 years or more, or it can be both urban or in the rural areas. So what to look for in selecting the algorithm for diabetic retinopathy screening? The number of images in the training set. So first we have to make one training set, and there will be multiple number of images. So if the number of images are much more, then the making the algorithm will be correct. And how was the ground truth ascertained? And whether the algorithm was trained on the mediatic or non-mediatic image. So if we'll make the algorithm using non-mediatic people, then the latter, when we do the screening, we can use in the patient with the non-mediatic pupil. Or whether the algorithm was trained on a single field or multiple fields. Single field means sometimes the algorithm can be based upon only OCT, sometimes with OCT, fundus photo, OCT angiography can be together and made the algorithm. So if we make the algorithm with the multiple fields or multiple investigation modalities, the chances of accuracy will be much more. So the selecting the algorithm, it depends on the circumstances on the intended screening. So what will be the final outcome in the AI-based system? So the final outcome will be seen as a referable DIA, non-referable DIA, or it can be as a ungradable images, or either hospital, if it is ungradable images, so hospital referral will be needed. And it can be the vision threatening diabetic retinopathy. So the result will come as a referable DIA, non-referable DIA, ungradable image, or vision threatening DIA. There can be many challenges in this system. So there can be regional variation in the outcomes. So regional variation means if we take data from one region and if we do screening in the other regions, so that there can be some alteration in the result, and there can be inter-grader variations. There can be agreement between the human graders and the algorithms. So here we'll show the establishment of the AI algorithm. So here is the fundus photo based AI algorithm, so taken in the clinic, and there's image processing as we have then have done image processing and large scale database compilation, and there are deep features of the learning, and there are these features was extracted from by the deep learning system, and the result will be like is it healthy retina or abnormal retina. So in this fundus heat map in the right hand side, if the heat map is overlaid on the fundus images, we can see the overlay map here on the fundus images, and this overlay map will detect the abnormal area of the fundus. So how will detect the diabetic retinopathy? Using the AI-based system. So in this fundus photo, the AI-based system can detect the superficial hemorrhages, deep hemorrhages, and the hard exudates with the deep learning system. And in this fundus photo, it is severe NPDR, and in this right side photo, there is heat map, means there is bright areas. So these bright areas is suggestive of the abnormal fundus. And this is the OCT of the diabetic macular edema, and the heat map, these bright red areas is showing the diabetic macular edema with the AI-based systems. So what are the commercial products for the diabetic retinopathy screening? This IDX DR, this is FDA approved, so used in the US usually. So IDX DR analysis will give a report like this. This is the vision threatening diabetic retinopathy. And the iris selena, this is the European Union uh, permissible commercial product for the diabetic retinopathy screening. So there are few deep learning system which use the test data like Macedo2, IPEX1, and EOPTHA, and they use these deep learning methods for the screening of the diabetic retinopathy. And all this study is showing the sensitivity and specificity is almost 90%. Means the artificial intelligence have a great role in diabetic retinopathy screening. One important thing, can we detect the diabetic retinopathy without seeing the fundus? The answer is yes. Yeah, the pupil are the different in the diabetic retinopathy. First is the baseline pupil diameter. So the baseline pupil diameter will decrease with the increasing severity of the diabetic retinopathy. So another two things is the mean velocity of pupillary constrictions and mean velocity of pupillary redilatation. So both these will decrease as the diabetic retinopathy grade will increase. So the pupillary dynamics are abnormal in the early stage of diabetic retinopathy and progress with the increasing retinopathy severity. So another one important thing is diabetic neuropathy. So can we predict the diabetic neuropathy from the retinal images? Yes, the retinal sensitivity can be checked with the microperimeter in the right side image. This is the microperimetry image, and here in one point, this is denoted with the orange color with a red arrow. This sensitivity is only 14 decibels. Other areas are like 25 to 30 decibels. So there is decreased sensitivity in this patient. So in case of diabetic neuropathy, so there will be retinal sensitivity loss before diabetic retinopathy will develop. So we can detect diabetic retinopathy from before. There will be increase in the foveal thickness. There will be reduced RNFL thickness also along with that. So the retinal images from the people with diabetes can be used to identify individuals with diabetic neuropathy, and simultaneous screening of neuropathy and retinopathy, it can prevent the microvascular complications of the diabetes. So how to predict the response based on inflammatory markers? So macular edema can be because of uveitis also, and the deep learning algorithm can detect these markers. So we can use this algorithm to differentiate between the diabetic macular edema with the uveitic macular edema. And this algorithm can differentiate between the responder or non-responder to the treatment. There is another one important thing, that is ocular ultrasound. So the ocular ultrasound based AI system can detect multiple retina problem. So one is here ultrasound scan is showing the retina detachment. Here is choroidal detachment, and there is tractional retina detachment and subhilar hemorrhage. So in all these retina conditions, we can see the bright red color in the abnormal retinal area. So here in the subhilar hemorrhage, what we seen in the ultrasound B scan, we can see the heat map. There is bright red area. So the AI system can detect the retinal pathology by this. So what is the situation of artificial intelligence in diabetic retinopathy in India? So in the absence of legal framework for use of artificial intelligence in diabetic retinopathy screening in India, so it is empirical for the ophthalmologist to grade all those who are identified as a referable DR. Means whatever patient through the AI assisted system is screened as a referable DR and coming to the base hospital, the ophthalmologist should grade the diabetic retinopathy in this situation because the legal framework are not generated still. There are situations when the AI has no use. When the patient with known retinopathy means already diagnosed as diabetic retinopathy or prior treatment was given in case of diabetic retinopathy and there are symptom of vision impairment and already diagnosed as diabetic retinopathy. So in this situation, as because the patient is already diagnosed as diabetic retinopathy, there is no use of AI tool to screen the disease. So next important one is age-related macular degeneration, which is the leading cause of visual impairment and irreversible blind loss worldwide in the elderly population. It is estimated to increase to 288 million in 2040, and approximately 8.7% of all global blindness will be due to the rapid increase in the aging population. So how to establish the AI tool to screen the ARMD? So most important is the optical coherence tomography OCT. Why? Because the huge number of macular OCT are routinely done around the world, and this macular OCT has the dense three-dimensional structural information, which we can get consistently. Means in one OCT, the multiple scan will be captured in the one area, and OCT can provide the structural detail. So this, if we'll use OCT in AI-based system, it is a huge importance and huge advantage and we'll get the huge number of OCT also. So in this photo, we can see the three OCT pictures of ARMD, and in the lower photo, there is bright area suggestive of some retinal pathology because of ARMD. So this ARMD can be diagnosed with some color coding map also. So in this article, they have explained the interrupted outer retina as a pink color here, the interrupted RP as a leg blue color, and yellow color it denoted the absence of outer retina, and absence of RP by the dark blue color here. And hypertransmission less than 250 micrometer with the red color here, and hypertension more than 250 micron with the green color. So with this color based imaging system done by the AI tool will help us to easily detect the ARMD. And this right hand side photo is advanced AMD by the fundus photo, and the heat map is showing the bright colors suggestive of the abnormal retina. So here is the deep learning network, how it formed. So this is a digital OCT scan and 877 manually segmented trained images were taken and tissue segmentation map was done, and then 14,000 trained tissue maps with confirmed diagnosis and referral decision was taken. And how is the final result? So the final result will come like which will need urgent referral, semi-urgent, or it can be managed routinely or can be observed as of now. And the diagnosis can come as a normal macula or CNB or vein occlusion macular hole, CSR, or can be vitreomacular traction. And in this right side image, we'll comparing the OCT based AI system with the retina specialist here. So in this three system, this is all these three are comparable. So this OCT based AI system has told to refer urgently 234 patient. Here it is 228. So the results are almost equal. So what are the commercially available deep learning system used in the ARMD? AlexNet, GoogleNet, VCG, Inception V3, ResNet, and Inception ResNet V2. So next is retinopathy of prematurity. So it remains a leading cause of childhood blindness worldwide. There are many challenges to deliver of care. So, because the clinical diagnosis is highly variable and there is high inter-observer inconsistency even with among the ROP experts. And the number of ophthalmologists and neonatologists, those who are willing or able to manage the ROP able to manage the ROP is insufficient. The reason being the logistic difficulties, extensive training process, time consuming examination, and significant malpractice liabilities. And above all that, the incidence of ROP worldwide is raising because of the advance in neonatology. So what is the solution? The solution is the AI, the computer-based imaging analysis. So here is one example how the AI-based tool process the image. This image number A is the real image taken by the red cam, and image number B after the image processing, and D is the final image processing. So first image we can see the reach properly, but in the last image after all image processing we can nicely detect the reach. And the ROP means the AI based system for the ROP screening will give result like this. This is the scatter plot. This sky color plots are for the plus disease. These are for the P plus, and this is for the normal fundus. So this AI based ROP screening tool, whatever commercially available is the iROP, but it has many limitations. Like it is robust on the data as the data on which they are trained. So if it is if it will give data from the other areas or other locations, say the result can be wrong. And the system currently only classify plus diseases, not the other form of the ROPs. So the fully automated ROP screening platform can be generated to classify other ROP, to grade the ROP, not only the plus disease or pre-plus diseases. Next, the important is cataract. So cataract is the leading cause of the visual impairment worldwide, accounting for 62.5 million cases of visual impairment. And nowadays, the cataract screening is done with slit lamp biomicroscopy with the lens opacities classification system 3. But it has many limitations, like it is manual process requires like clinical expertise. There is shortage of the trained ophthalmologists, and grading results are compromised by the inter-examiner variability. So the screening for the cataract, the algorithm can be based on the slit lamp photo, can be based on the fundus photo. These all are the example of the slit lamp based algorithm. One is active shape model ASM. This identifies the location of the crystalline lens and its nucleus on the slit lamp photographs, and is achieved 95% success rate. And another one example is cloud based artificial intelligence is CC Cruiser to diagnose and grade the pediatric cataract. This right hand side is the flowchart, how the image can be processed. So the first images were taken, and this is the data uh, was there from before, and the processing of the images done here, and this is the deep learning and machine learning procedure, and we'll get the result, like how much is the sensitivity, specificity, and we can compare with the experts. So this is one example, this ResNet 3, this is one example of slit lamp based AI algorithm. It first differentiates slit lamp photograph between mediatic and non-mediatic image, and between the optical section and diffuse slit lamp illumination. An image would categorized as a normal, like no cataract, cataract, and postoperative IOL. And then the severity of the cataract and PCO, posterior capsular opacity, can be detected by the lens opacity classification system 2. This is algorithm based on fundus photography. This is ResNet 18 or ResNet 50. So here we can see the fundus photo is very clear. Here it is hazy. So this fundus photo was taken from the patient without cataract and is taken from the patient with cataract. So after seeing this fundus photo, the AI algorithm can detect the grade of cataract. Another one important thing is AI-based IOL. It can be called as the intelligent IOL. This Swiss advanced vision, this mimicking human lens, because there is two optical membranes in both sides and there is a liquid inside. So the autofocus system sends signal that trigger micropumps. There are many micropumps here. So these micropumps to alter the curvature of the optical membrane and through the liquid displacement, and it acts to the liquid displacement. So this process occurs in only 0.2 seconds, a speed equivalent to the accommodation of the healthy human eye. So there are a few algorithms for the IOL power calculation. One is ladder super formula. This is the combination of all existing formula like Hoffa-Q, Holiday 1, SRK2, and the plotted into the 3D surface. And one is RBM method, Hill radial basis function method. So it is based on the Hackster-Leinster optical bar meter. And the Kane formula, this is cloud-based formula. So, but there are many limitations of AI use in IOL power calculation. One is the post-refractive surgery. This is always a challenge to calculate the IOL power in post-refractive surgery patient. So, new AI-derived formula may explore to improve the accuracy of IOL power estimation in these patients. And AI always need large data. So, the large data will need some storage space. So, that is always a challenge. So, the hospital electronic medical record coupled with the cloud storage may offer new opportunities for the development of the algorithm. So, what is the future of AI in case of cataract screening? So nowadays, mostly used devices is the smartphone. So if handheld retinal cameras or slit lamp adapter is attached to the smartphone and can be potentially provide better outreach for the cataract screening, especially the rural and the less resourced areas. And the diabetic retinopathy screening can be combined with the cataract screening, and there will be reducing of the additional cost. And the recent AI work has demonstrated its capability in recognizing the different phases of cataract surgery. So it will be very useful for training of the ophthalmology residents. Next, the important disease is glaucoma. So in glaucoma, we can get the RNFL thickness map that can be extracted from the SSOCT scan. So this above photo is showing the in first images and RNFL thickness map. So when the image processing happens with the deep learning system, this RNFL defect is shows the bright areas. So this bright areas is suggestive of the RNFL defect, and it will help for the glaucoma screening. Another one AI-based system for glaucoma is this is for the visual field based system. So here the 16 archetypes of the visual fields are there. So except the archetypes 12 and 15, all other archetypes of visual field are because of glaucoma. So this can be helpful in the AI assisted system and can screen the glaucoma. Here is one example of the how is the treatment response. In the first visit, there is field effects is much more. In second visit, there is some improvement. Third visit, a lot of improvement. So uh, this AI tool can help to prediction for the treatment. Means how is the treatment going on. And there is one focusing method. So in this method, this Kelman filtering, the novel glaucoma focusing tool, in this method, they divide the glaucoma patient in two groups. One is first progression, one is slow progression. So in first progression, we can see the change of mean change of IOP is much more in the specific period, but in the slow progression group, it is less. So in case of first progressor group, the target IP should be very low, and the slow progressor group, it can be little more. So AI can be used in other anti-segment disorder also, like conjunctival hyperemia grading. It can be used in the posterior capsular opacification progress prediction, angle closure detection, tear film lipid layer classification, or dry eye diagnosis. Can be used in dry eye detection, BUT calculation, and case of cataract grading already discussed, and corneal arcus and cataract detection. So another one important implication is in case of keratoconus. So we can detect keratoconus preclinically. So bilateral data can be taken. The data can be taken from the normal fellow eyes of the patient with keratoconus, and it can be compared with the normal eyes. And the simpler camera was used to take all these photos. And the most sensitive parameters to date for the early keratoconic detection is a combination of video keratography, wavefront analysis, and optical coherence tomography. AI can detect the amblyopia also. So this is U-vision tab stereo vision test, which can detect amblyopia or amblyogenic or non-amblyogenic condition in the children. It do not rely on the measuring stereo acuity, can be either static or dynamic, can include uncorrelated noise, and use artificial intelligence technology. So in this first photo, we can see the universally visible E. Uh, so on the left hand side, the child is viewing a control display that is universally visible, allowing the child to respond accordingly. Conversely, the right hand side features the images that is exclusively visible on the to the child wearing the red clean glass. So the child can complete the test by pressing the corresponding key. So how this U-vision tab stereo vision test can detect the amblyopia easily. Artificial intelligence can be used in squint surgery also. So strabismus that affect the 4% of population, and strabismus surgery is always complex, demanding both theoretical knowledge and experience from the surgeon. Here comes the role of support vector regression. This support vector regression can help physician to take decision related to horizontal strabismus surgery. But one limitation is it cannot be used still with the vertical and oblique muscle surgery, because the number of vertical and oblique muscle surgery are less. So getting the data, huge data, will also be difficult. So still it is this algorithm is for only the horizontal muscle surgery. So here I will show the support vector regression map. So here the data set of the surgical plan was put, and this is the training data set. The data of the patient already operated. So these two data set will help to the regressor process, and the test data set combined will give the result. So the surgeon will get the surgical plan. So how much resection or recession to be done. But the AI system also is not free of challenges. It requires a large amount of data, because the insufficient data may decrease the performance of the deep learning models. And the low incidence of the rare diseases make it difficult for the researcher to collect data. So the AI system has limited role in the rare diseases. And sometimes there can be requirement of the prospective data. So it is very time consuming and energy consuming. So these all are the limitations of the AI systems. Sometimes AI often overlook clinically relevant details. For example, the criteria for participant recruitment, demographics, risk control. So there should be some standardized reporting protocol like Consort AI, STAD AI, Spirit AI, and Tripod. There can be security and ethical problem, because the medical artificial intelligence research should performed on the multi-center database, and data transfer means data transfer should be done. So when the data transfer will be done with the multiple centers, there can be some security problem. And ethics. So the AI is gradually being integrated in the clinical practice, and the medical professionals are getting used to it. So there should be some ethical framework to guide the real application of the deep learning system. So one important thing is the AI-based systems, AI-based screening is acceptable to the population. This interesting article shows, so most of the patient had a positive perception on AI-based retina screening. The positive attitude and acceptance of AI-based screening among patients who visit the hospital for routine eye screening. And 90.4% patients were willing for AI-based screening, mostly the diabetic, the young men, they think the screening can replace the doctor's visit for a just routine screening. And 9.6% patients were not willing. Why? Because the reason given by them were moral support, human touch, and trust in the doctor. The patient was satisfied with the idea of being screened by optometrists and AI before visiting the retina specialist. They felt that that would prepare them mentally and save time and money for traveling. So last but not the least, to remember, the deep learning models means the AI methods have achieved performance close to even surpass ophthalmology in specific medical tasks. But the real practical application of AI system in complex ophthalmology clinics is still far from being achieved. And if an AI algorithm is trained or tested in a database in the certain population, so this algorithm may perform poorly in the other groups of population. The future of the AI intervention in ophthalmology seems promising, but there is still a long way to go prior to the wide clinical applications. So here are my acknowledgements. Thank you all for the patience.
Excellent, sir. It was a
I'll stop
wonderful
sharing.
presentation. Yeah, you can please stop sharing. Excellent presentation, and I think you have brought out the nuances of all the fields where AI can actually be applicable in ophthalmology. And yes, today that is going to be our future. So we would like our discussants now to give their views and their experiences. We can start with Professor Kavita ma'am. Your
Uh, yeah, excellent presentation, Dr. Pradhan. Too good. Yes, we have come a long way in using artificial intelligence in ophthalmology, and there's still a long way to go. And in times to come, definitely, like telemedicine, we were initially quite skeptical, but during COVID time, we realized the importance of tele ophthalmology and telemedicine. So similarly, AI also in times to come, I think we will realize that this will become our right hand. It will save a lot of human hours for wasted in screening, like say, I mean, diabetic retinopathy or glaucoma or ROP, or they are very time consuming, and with lot of health hazards, like lot of my retina colleagues, they complain of backache and cervical pain and all, maybe. So this will save us from that trouble, and will definitely, I mean, we'll be able to use our time for better thing, more important things like treatment and other aspects. So yes, definitely. And I think across all anterior segment to posterior segment, I think we can use it.
Yeah, Dr. Subudhi sir, what has been your experience and your inputs, especially if you look at today, even for diabetic retinopathy, India is the diabetic capital of the world. So there are going to be so many diabetics who are educated but who don't realize the importance of doing a regular retina check. And whenever they come to us with an advanced disease, we really feel sad that these patients have not been screened. So how do you think, especially in such a scenario, how this is going to help and how much is it being done today by all of us?
Absolutely, madam, you told rightly, you said. So, as you know, we are advocating teleophthalmology, and I'm the General Secretary of Teleophthalmology, and we have got a lot of discussions in teleophthalmology, last few seminars and few conferences. In teleophthalmology, we use this particularly portable instruments like fundus camera. You know, the, I don't have any financial interest, but you must have seen that Remedio fundus camera is one of the best portable camera. Now they have come up with AI. So I'll give one example. A patient, a 52-year-old lady, came to one of our vision centers, and she is a diabetic for many years, taking irregular medicine. When she developed slight impairment of vision, she came to the vision center for a pair of glasses so that she can see better. So one of our health worker, he did a screening of this patient because he was a diabetic for last 10 or 15 years. So he found out one lesion, and this camera is AI supported. So immediately detected the diabetic retinopathy in this patient. So he consulted with the base hospital with us, and we saw that the patient is having advanced proliferative diabetic retinopathy in both eyes. So immediately the patient was referred to us, and we started the treatment with lasers and injections, etc. And the patient's vision is restored. So it's one of the best example of teleophthalmology with AI. So probably another one patient I would like to say was a doctor, a cardiologist, one of my friend. He visited one of the conferences in Hyderabad. In Hyderabad, there is a stall with a remedy fundus. Out of curiosity, this person has gone to that stall and showed his eyes. And he was found to be having two irregular disc cuppings. One of the cup is a little larger. So again, that machine told that it's a referable glaucoma. So he referred the patient or referred the cardiologist to the ophthalmologist. When he came to me, I saw that the pressure is more than 25 in both eyes. And we have started the treatments. So these are one of the few examples, like in glaucoma, then your diabetic retinopathy. These are the plays immense role. AI plays immense role. Similarly, in ROP also. If you can screen the ROP babies in the rural areas by a simple camera, portable camera, this key drop technique in Karnataka, they are doing a lot of things on this, develop a lot of things. So if you can screen these patients, probably you can detect the early ROP and we can treat them or guide them. So definitely AI has a role, provide better diagnosis and recommends treatments too. As you said, one of the IOLs. So the best IOL can be detected by the AI. And of course, preventing physician burnout. Nowadays, the doctors are mostly overworked. And if AI supported instruments are available with us, probably you can cut short in the operation theater and the diagnostics, particularly ophthalmologists. Definitely, it will reduce our time for the diagnosis. And providing also better health care to the elderly people. The elderly people sometimes with robot assisted, this AI assisted robots, they can help these elderly people in movement in their homes so that they can have much benefit. Last but not the least is the simplifying hospital visits. Nowadays because the number of patients have increased, so patient have to make a queue to get an appointment with a particular doctor. If already AI-based instrument is available, you can give at a particular time so the patient can comfortably visit the consultant and he can show his eyes. So AI is now developing, giving a lot of benefits to but it will not replace the human being.
Absolutely.
Or the doctors. It cannot. Rather, it can support the doctors, but don't think that AI will replace the doctors in future and we doctors become, idle or jobless.
Yes,
So
absolutely. So it is up to us how we use science, whether you make it a boon or a bane, and how it is. Is there any way, Dr. Rajesh sir, you are a cataract specialist, so Dr. Pradhan was also elucidating how it can be used to diagnose cataract. Now, even today, we get a lot of patients coming to us for second opinion, saying that XYZ doctor says there is a cataract and you need to get surgery done. Now, if he comes to you for a second opinion and you had, say, an AI tool, would it help to show the patient how more accurate your diagnosis is vis-a-vis just a routine ophthalmologist? Or what is your thought on that? Dr. Rajesh?
Yeah, I think whenever you consider it as a surgical procedure, as far as cataract diagnosis is concerned, definitely, if you need to operate this patient, then you have to see this patient and decide upon whether he needs surgical procedure or not. Even if AI diagnoses his cataract, the surgeon should see that whether he needs to undergo surgery or not. I think surgeon's perspective as far as diagnosis is concerned is important in this case rather than sending patient to here and there. I think surgeon should give his opinion about the procedure, whether he needs to undergo surgical procedure or not.
Right, absolutely. Dr. Pradhan, I wanted to ask you something. Like, we have now seen what is the scope of AI. Now, what are the fallacies and where do you think that it falls short or it could even mislead? And where should we as ophthalmologists be careful and alert that this can also cause, like, for example, OCT in glaucoma? The moment you see red, people start thinking, yes, you have glaucoma without even doing the other glaucoma test. So at the same time, as we know how important it is for helping us screen patients and give more and more patients the benefit of doubt of the diagnosis, at the same time, we should not mislead or scare the patient by giving a false diagnosis. So how can we be more careful and what are the areas which you think are where we need to be more alert?
Yeah, sometime in case of rare diseases, so the getting the algorithm means data will be less. So making the algorithm also will be very difficult. So in case of rare diseases and sometime in common diseases also in diabetic retinopathy like diabetic macular edema, sometimes the other causes of macular edema, there are algorithm to detect that, but there are other causes of macular edema. Sometimes it can be mixed up with that. So sometimes the AI tool cannot detect properly the diabetic macular edema, or there can be if there is some hemorrhages because of some other reasons like vein
Exactly.
occlusions and all that, so it can detect as a diabetic macular edema sometimes, and in always in case of rare diseases, so it is difficult to detect.
Right, right. Even we are using the Remedio for screening purposes, and many times it has happened that either it misses out or it gives it as diabetic retinopathy, where actually it may be something else. So I think we as ophthalmologists should also be very careful as to what we convey to the patient after seeing that. We just have it should be used as a guideline, and we have to continue to do our detailed investigation clinically and using other diagnostic devices, and not rely only on this.
Yeah,
And the patient also should be made aware that this is just the beginning. It is just a guideline, but you will have to still undergo all those tests. He should not feel, so ye to ho gaya, my diagnosis is made, and now, I don't need anything else or something like that.
yeah,
Probably.
yeah, yeah, that counseling part will be important, means if we use the
Something
AI
about-
based systems, so means for that the counseling part also will be very important.
Dr. Pradhan, and
Yeah.
sometimes do you have any chance of a bias in this diagnosis and the treatment of this AI-based algorithms?
AI.
Suppose if you give wrong diagnosis, or suppose your power you are calculating, suppose it's a wrong power calculation, and
Yeah,
you land in trouble.
yeah,
Is it
yeah.
possible?
Yes, this exactly for power calculation, I don't know, but usually we screen the diabetic retinopathy patient. So that sometime that just now we told, sometime it can giving the wrong impression or macular edema because of the other reasons. So it detects as a diabetic macular edema. So it happens. So
What are
If
the
it,
medico-legal implications of
yeah,
it?
medical legal implications.
Medico-legal implications of diagnosing someone as something, for example, and the
yeah,
patient doesn't come back to you, is lost to follow up, and
yeah,
maybe, what
yeah,
medico-legal implications of
And you
it?
yeah.
get a notice. You get a notice.
Yeah, so there will be a lot of medical legal problems also, that ethics. So that's why, because when the users will be more, that this ethical problem will come in front.
Do we obtain consent before examining these patients? Because ultimately we
Yeah.
are capturing pictures, no? So they will be transferred to database or they will be published also. So do we take any consent, like you will be examined, your photographs will be taken like that?
Yeah, before means for the all OPD patient, we take the consent. That OPD form that contains the consent for the examination and for the investigations also. We don't take any separate consent form for the all this, but this OPD means all OPD patients we use, means we take some consent. So everything is written on that.
Dr. Pradhan, you mentioned about diabetic retinopathy diagnosis, no? So
Yeah,
most of the pictures are like having established cases of diabetes, like in database, neural
yeah,
net or whatever.
yeah.
Uh, are there any databases in which where you can detect rheological changes in the retina so as to diagnose these cases before having diabetic retinopathy?
Uh, so yeah, are you asking the diabetic neuropathy patient or?
No, no, rheological, like blood changes, changes in the blood
You
vessels.
mean to say predicting
Yeah,
Yeah.
before it actually develops,
yeah,
predicting whether the patient will develop diabetic retinopathy or not? Is that your question, sir?
Yeah, yeah.
I think he mentioned about pupil. He mentioned
yeah,
about pupil, that is before the patient develops
yeah.
retinopathy, which gives you some.
Yeah, there will be the basal pupillary diameter and the
Yeah.
constriction, means the velocity of constriction and velocity of redilatation. So these three things, without seeing the fundus, we can predict sometimes the severity of the diabetic retinopathy.
Yeah, but like before the changes develop, before pupillary changes appear, before the changes in the retina itself, like
Yeah, there is something we can use the perimeter that is actually used in case of to detect the diabetic neuropathy. We have seen the diabetic neuropathy cases. So in that diabetic neuropathy cases, if we do the microperimetry, we see there will be some decrease in the decibels in some region. So I have shown one article that was showing some decrease in the sensitivity in the microperimeter. So like that we can detect actually.
Even looking at the fundus picture, you can predict cardiac complications and even kidney complications also, because they all go together. If you see a microaneurysms or microvascular angiopathy in the retina, probably they also give a prediction by the cardiopathy and microangiopathy in the kidney.
Yeah.
So these are the developments. I think maybe AI can predict that by looking at this fundus picture, can the patient have a myocardial attack, or can the patient have a kidney nephropathy problem or neuropathy, as you said?
Yeah. Yes, sir. That Google AI tool, they are working on that.
Yeah, and then even diagnosing systemic diseases other than just diabetic retinopathy or hypertensive retinopathy, any kind of cardiac events, or I think even the gender can be seen just by seeing the fundus picture. That also has been
Yes.
found.
Yeah.
Actually, the scope is limitless, but in a short time, you have actually put everything into your topic, and I think it covered everything and gave a very nice overview of how AI can actually help transform ophthalmology. And I think it's a revolutionizing concept. And in the years to come, we will see more and more AI and more
Yes.
devices that are going to use AI and maybe help make diagnosis much more easier, simpler, and detect uh, diseases much earlier before it can actually threaten vision. So, thank you so much, Dr. Pradhan, for such a lovely
Yeah, ma'am.
presentation.
Yeah, thank you so much.
And thank you so much to our esteemed discussants, Dr. Subudhi sir, Dr. Vatnagar ma'am, Dr. Rajesh Joshi, for sparing your valuable time and joining us here and discussing at length of all the various applications of AI. And I hope this webinar has been useful to all our postgraduates as well as all those who have seen and who will view this in future, because this is going to be on YouTube and it will be like in the annals of the AIS ARC. I'd like to also thank our AIS president, Dr. Samar Basak sir, who has always been so supportive, encouraging for all our activities of the ARC, and our chairman ARC, Dr. Prashant Bavankole, who has thought of all these interesting topics and has brought about such a nice change and brought out fresh topics for, especially for our postgraduates. Like to also thank our support for the webinar. Thank you so much. So again, thank you everyone.
Thank you all.
Thank you. Bye-bye.
Thank you so much.
Thank you all. Thank
Thank
you
you.
all. It's a
Bye.
really nice webinar. I
Thank
think a
you.
lot of
Bye.
time tested.
Thank you.
Thank
Sunil.
you.
Bye
Thank
bye.
you.
Good night.
Pleasure to be on this platform. Thank you. Bye-bye.
Thank
Thank
you.
you.
Okay.